Related Disorders Unit 7 Eating Disorders. Structure 7.0 Introduction 7.1 Bulimia 7.0 Introduction. When someone loses a lot of weight or looks extremely skinny, often people tell the person, "You look anorexic." Often this comment is intended to be a compliment, but anorexia is a type of eating disorder, a serious condition involving excessive dissatisfaction with one's body weight that requires professional help and family support. Dr. Idisha Nagar, Assistant Professor of Psychology, Kamala Nehru College, University of Delhi, New Delhi. 190. Mood disorders, psychotic disorders, somatic symptoms and eating disorders. Almost everyone has looked into a mirror and experienced dissatisfaction with their weight at some point of time in their lives or other. Body dissatisfaction and weight concerns are especially common amongst women. For some females it starts as early as middle school. It is also not uncommon to find weight concerns in older women. Body dissatisfaction may be healthy and adaptive in some individuals as it may motivate them to lose weight and change to a healthier lifestyle. Achievement of normal body weight through regular exercise and healthy eating is beneficial for our physical and mental health. However, in some individuals the concern about body weight is somewhat more extreme. They are likely to think they are overweight even when they are not. They may engage in excessive dieting and vigorous exercise to lose weight, which in turn may lead to negative social, emotional, behavioral and medical consequences for the individual. This drive for thinness leaves them distressed and dysfunctional that is affecting their interpersonal, social, and occupational lives. Under these circumstances, the experience of intense body dissatisfaction is likely to be classified as an eating disorder. Eating disorders are defined as severe disturbances in eating characterized by 1. Weight concerns, 2. Body dissatisfaction, and 3. Eating problems that are more extreme than the norm, causing the individual significant distress and dysfunction. In this unit, we will look into the clinical features, causes and treatment of anorexia nervosa, bulimia nervosa, and binge eating disorder. 7.1 Bulimia nervosa eating disorders was recognized as a separate group of disorders in DSM-IV. DSM-5 classifies three major types of eating disorders. First, anorexia nervosa, in which the individual eats minimal food and the body weight drops to dangerously low levels. Second, bulimia nervosa (ISA) condition, in which the individual engages in episodes of binge eating, uncontrollable eating, and then indulges in self-induced ways of throwing the food out like vomiting, use of laxatives, or other attempts. Finally, binge eating disorder is a condition in which individuals binge repeatedly, but the episodes are not followed by compensatory mechanisms to throw the body out. Figure 7.1. Major types of eating disorders. Eating disorders. Bulimia nervosa. Anorexia nervosa. Binge eating disorder. Purging type, restricting type. Non-purging methods type. Binge eating purging. Type 191. Eating disorders. Recent studies suggest that the number of people diagnosed with eating disorders is increasing over the years and are not restricted to Western countries. Until recently, eating disorders were not found in developing countries. People in developing countries like India were struggling with problems of malnutrition and daily struggle to afford sufficient food. However, latest researches suggest that eating disorders are on the rise globally. 7.1.1 Clinical picture. The word bulimia comes from Greek word bous, meaning ox, and limos, hunger. The core feature of bulimia is recurrent episodes of binging, that is, eating large amount of food, typically junk food, than most people would in the same situation, followed by use of compensatory mechanisms, vomiting, excessive exercising, laxatives, dieting, etc., to overcome with the guilt of weight gain. For instance, Princess Diana would have binge episodes in which she would eat up anything she could get her hands on and would then induce vomit to throw the food out. A typical binge and purge episode is characterized by the following. 1. Eating much more rapidly than normal. 2. Eating until feeling uncomfortably full. 3. Eating large amounts of food when not feeling physically hungry. 4. Eating alone because of feeling embarrassed by how much one is eating. 5. Feeling disgusted with oneself, depressed, or very guilty afterwards. Apart from eating a large amount of food in short duration, binging is also characterized by experience of lack of control. This feature was also present in binge episodes of Princess Diana. Initially started as a new method to diet, she found herself increasingly losing control with every subsequent binge episode. Another important criterion is that the individual uses inappropriate compensatory mechanisms to prevent weight gain. Based on the method used, bulimia can be classified as binging and purging type and binging and non-purging type. In the purging type, the individual induces vomiting, whereas in non-purging type, the individual uses other mechanisms including misuse of medicines like laxatives, drugs that relieve constipation, diuretics, drugs that result in loss of fluids through increased urination, enemas, or any other medications, long period of fasting and excessive exercise. Majority cases of bulimia are the purging type, and researchers have found little evidence of any major differences in frequency of binge episodes, comorbid disorders like depression and anxiety, and severity of the psychopathology between the two, and thus, DSM-5 dropped the distinction. DSM-5 has added a criterion that was not previously there in DSM-IV. Self-evaluation in people with bulimia nervosa is unduly influenced by body shape and weight. People with bulimia believe that in spite of their various achievements and success, their self-esteem and popularity will be largely determined how their bodies look. For instance, from the outside, Princess Diana was loved by all for her generous nature and charity work. However, she exclusively focused on the shape and size of her body. See Box 7.1. Box 7.1. Case Study. Bulimia nervosa. Princess Diana revealed that bulimia nervosa began for her a week after her engagement with Prince Charles of England. She recalled how her then fiancé, Prince Charles, put hand around her waist and said, "Bit chubby here, aren't we?" Princess Diana discovered that she could lose weight if she binged on food and then vomited it out later on. She recalled in an interview, anything. 192. Mood disorders, psychotic disorders, somatic symptoms and eating disorders. I could find I would gobble up and be sick 2 minutes later. She felt thrilled at first at finding a new method of dieting, but increasingly found herself in a downward spiral. She confessed that her eating problems were intensified because of her troubled relationship with her husband. Years later, she was finally forced to seek help. Diana said during the 1993 speech, "From early childhood many had felt they were expected to be perfect, but didn't feel they had the right to express their true feelings to those around them, feelings of guilt, of self-revulsion and low personal esteem, creating in them a compulsion to dissolve like a despairin and disappear." In the speech, Diana commented about the possible role of expectations of perfection and low self-esteem in the development of bulimia. Later in life, Diana became an eating disorder awareness advocate. Figure 7.2. Princess Diana Source, https://starcasm.net. Box 7.2. DSM-5 Criteria for Bulimia Nervosa, Oppa, 2013. A. Recurrent episodes of binge eating. An episode of binge eating is characterized by both of the following. 1. Eating in a discrete period of time, example, within a 2-hour period. An amount of food that is definitely larger than what most people would eat during a similar period of time and under similar circumstances. 2. Lack of control over eating during the episode, example, a feeling that you cannot stop eating, or control what or how much you are eating. B. Recurrent inappropriate compensatory behavior to prevent weight gain, such as self-induced vomiting, misuse of laxatives, diuretics, or other medications, fasting, or excessive exercise. C. The binge eating and inappropriate compensatory behaviors both occur, on average, at least once a week for 3 months. D. Self-evaluation is unduly influenced by body shape and weight. E. Binging or purging does not occur exclusively during episodes of behavior that would be common in those with anorexia nervosa. 193. Eating disorders. 7.1.2 Binge and purge cycle. The binge and purge cycle usually begins with excessive dieting, that is almost starving oneself, motivated by a desire to look thin. During these early stages, the person diets and eats low-calorie foods. Extreme diets can aggravate the associated negative emotions like anxiety and stress. Combined with hunger, Anxiety can trigger a binge episode in which a person starts to eat junk food like chips, cola, chocolate, pizza, ice cream. While initially, a binge episode feels good, but soon enough the person starts experiencing shame and self-hatred over the loss of control. The person begins to vomit, fast, exercise excessively, or abuse laxatives. Even though people with bulimia are disgusted of their behavior, binging and purging persists. Figure 7.3. The binge and purge cycle in bulimia. Source: https://www.gersbooks.com. 7.1.3 Associated features of bulimia. People with bulimia are plagued with negative emotions like shame, guilt, embarrassment, and self-deprecation. For this reason, eating disorders often coexist with mood disorders and anxiety disorders. Further, there are severe medical consequences of bulimia nervosa. Excessive vomiting can lead to dental problems, swelling of salivary glands, esophageal problems, whereas overusing laxatives, diuretics can lead to chronic diarrhea or bowel problems. One of the most common side effects of abusing various medications as a compensatory mechanism for binging is dehydration. Continued vomiting can lead to electrolyte imbalance, cardiac arrhythmia, seizures, and renal failure, which can be fatal. Check your progress. 1.1. What are eating disorders? Thank you for listening. Please like and subscribe our channel. 194. Mood disorders, psychotic disorders, somatic symptoms and eating disorders. 2. Explain the binge and purge cycle in bulimia patients. Thank you for listening. Please like and subscribe our channel. 3. Describe some of the serious medical consequences of bulimia. Thank you for listening. Please like and subscribe our channel. 7.2 Anorexia Nervosa. 7.2.1 Clinical picture. Anorexia literally means lack of appetite induced by nervousness, but this definition is a misnomer because it is not a lack of appetite but a fear of gaining weight. In bulimia, majority of individuals are within 10% of their body weight. In contrast, people with anorexia are dangerously underweight. This is the defining feature of anorexia. People are significantly underweight relative to their age, sex, developmental trajectory, and physical health. However, people could lose significant amount of weight because of many reasons, including medical reasons. But in this significantly low weight of the individual is because of an intense fear of gaining weight or becoming fat. Although there is a popular misconception about people with anorexia, that they do not feel hungry, however this is not true. People with anorexia feel hungry and often think about food, but their intense dissatisfaction with their bodies drives them to almost starvation. People with anorexia are never comfortable with their body weight no matter how significantly underweight they might be. In fact, even staying the same weight, underweight, or gaining slight weight can cause intense panic, distress, anxiety, and depression. Finally, people with anorexia show disturbance in the way they experience their body. For instance, they may have distorted body image. While others may see themselves as emaciated and skinny, they may continue to see themselves as fat. Similar to people with bulimia, their self-evaluation may be unduly influenced by body shape and size. In spite of being told about the life-threatening consequences of their low body weight, they may show lack of seriousness towards these concerns. DSM-IV criteria for anorexia nervosa also included amenorrhea, or the absence of at least 3 consecutive menstrual cycles. For men, the equivalent of the menstruation criterion, diminished sexual appetite and lowered testosterone levels. However, this has not been found to be particularly useful criterion in the diagnosis and treatment of anorexia nervosa and thus has been removed in DSM-5. DSM-5 has specified 2 subtypes of anorexia nervosa. The restricting type that includes individuals who diet excessively to limit the calorie intake, and binging and purging type, in which they rely on purging. People with restricting type would skip meals, eat slowly, count calories consistently, drink a lot of water between meals to feel full, dispose their food when others are not looking, etc. 195. Eating disorders. Anorexia usually begins in adolescence, when an adolescent perceives self to be overweight. He then starts a diet that escalates into an obsession with thinness. Dramatic weight loss is achieved through restricted eating or by combining caloric restricting with purging. Figure 7.4. Distorted body image in people with anorexia. Source: https://www.dreamstime.com. Box 7.3. Case study: Anorexia nervosa. Anushka had always been a chubby child. Her friends and family always teased her for being fat. In particular, she remembered when she was in class 9th, one of her uncles commented about her body weight and shape: "You're so fat, who will marry you? Lose some weight." She remembers that she has always been discontent with her body weight, shape and size. In class 10th, she started actively looking for ways to reduce weight. Gradually, there was an increasing concern over growing fat. She started skipping 2 meals and would take only 1 meal and salad. She put up posters of female movie celebrities in her bedroom and would idealize them, often wishing to have bodies like them. She started exercising for 1 to 1.5 hours in order to compensate weight gain out of binging. She would binge on food 5 to 6 times a month and would regret afterwards and would try to induce vomiting. She even started smoking secretly to reduce weight, along with skipping meals in order to reduce her weight to below 45 kilograms, which was below normal for her height. Her family noticed that she was obsessed over her looks, weight, and spent hours in gyms and dieting. She could not spend even an hour without thinking about her fear of becoming obese. Over next 6 to 7 month period, she lost up to 20 kilograms and looked frail, although she still found herself being fat. Because she was still unhappy with how she looked, she went for a liposuction, cosmetic surgery for removing excess fat, without informing her family, and even sold her gold necklace to pay for it. Her academic performance deteriorated. She failed her class 11th exams. Her social life was almost non-existent. She did not have time to be with her friends who would find her weight obsession too weird and extreme. 196. Mood disorders, psychotic disorders, somatic symptoms and eating disorders. Box 7.4. DSM-5 Criteria for Anorexia Nervosa, Oppa, 2013, a restriction of energy intake relative to requirements leading to a significantly low body weight in the context of age, sex, developmental trajectory, and physical health. B. Intense fear of gaining weight or becoming fat, even though underweight. C. Disturbance in the way in which one's body weight or shape is experienced, undue influence of body weight or shape on self-evaluation, or denial of the seriousness of the current low body weight. Restricting subtype. Weight loss is accomplished exclusively through caloric restriction, that is dieting, fasting, and/or excessive exercise. The individual has not binged or purged in the last 3 months. Binge eating, purging subtype. The individual has binged, subjective or objective binge episodes, or purged in last 3 months. 7.2.2 Associated features of anorexia. Anorexia is associated with serious medical conditions. One of the most common medical problems is amenorrhea or cessation of menstrual cycle in women. Other problems include dry skin, brittle hair, nail sensitivity to cold temperature. Cardiovascular problems like low blood pressure and heartbeat can also occur. If vomiting is part of anorexia, then electrolyte imbalance can occur, leading to heart and kidney problems. With respect to comorbidity, as with bulimia, anxiety disorders and mood disorders are common in people with anorexia also. Substance abuse is also a comorbid condition in people with anorexia. One anxiety disorder in particular, Obsessive-Compulsive Disorder, OCD, often co-occurs. It has been noted that anorexia and OCD have some similar features. For instance, in anorexia there are intrusive thoughts about fear of gaining weight, and also individuals may engage in ritualistic behavior. Future research will be able to give us more clarity about whether the two disorders are truly similar or merely resemble each other. 7.3 Differences between anorexia nervosa and bulimia nervosa. First, people with anorexia who binge and purge are different from people with bulimia in being severely underweight, whereas people with bulimia are typically of normal weight. If a person who binges or purges also meets criteria for anorexia nervosa, he is given the diagnoses of anorexia and not bulimia. This is because there is greater mortality associated with anorexia than with bulimia. Second, unlike people with bulimia, people with anorexia binge smaller amount of food and purge more regularly. In some cases they may purge after every meal. Third, A typical person with anorexia would deny the seriousness of their condition, whereas a person with bulimia does not have this denial or a complacent mindset regarding her condition. Finally, it is not uncommon to find a feel of pride in people with anorexia regarding their diets, weight, and extraordinary control over them. However, people with bulimia are likely to be ashamed of both their eating issues and lack of control. 197. Eating disorders. Check your progress. 2.1. What is anorexia nervosa? Thank you for listening. Please like and subscribe our channel. 2. How is anorexia different from bulimia? Thank you for listening. Please like and subscribe our channel. 7.4 Statistics. According to Oppa, 2013, the prevalence rate is higher for bulimia nervosa, 1 to 3%, relative to the rate for anorexia nervosa, 0.5%. The age of onset is early adulthood, 18 to 21 years, with a greater number of women suffering from this condition than men. Hook and Van Hoeken, 2003. In case of bulimia, women receive 90 to 95% of the diagnoses. Jones and Mogan, 2010. Men have later age of onset, predominantly gay or bisexual. Rates of eating disorders are higher in men who are in sports that require weight regulations. It is important to note that the condition may be underdiagnosed in men as unlike women. Men do not have the same need as to reduce weight or shape concerns, their needs are concerned with muscularity. Eating disorders typically have a chronic course. Early childhood predictors include history of obesity and an overemphasis in family to be thin. They are difficult to treat and relapse rates are higher. However, over long-term recovery is possible. Even when people recover, residual issues with eating remains, such as concern with body shape and weight and a tendency to binge and purge when upset. Finally, as mentioned previously, eating disorders are on the rise across cultures and are no longer restricted to the West. 7.5 Causes of eating disorders. As is the case with all disorders, biological, psychological, and sociocultural factors contribute to the development of eating disorders. However, the most dramatic factors influencing the development of eating disorders are sociocultural factors. According to the diathesis stress model, biological diathesis, genetics or neurochemical features, that led to dysregulation in mood and eating behavior interacting with psychological vulnerabilities including low self-esteem, need to seek perfectionism, impulsivity, body dissatisfaction, and distorted body image, and environmental factors such as media-based pressures, child maltreatment, family conflict, social pressures, abuse, etc., resulting in eating disorders. 7.5.1 Biological factors. The biological causes of eating disorders can be identified on the basis of the following. 198. Mood disorders, psychotic disorders, somatic symptoms and eating disorders. Twin and family studies. Twin and family studies evince for the heritability of eating disorders. The tendency to develop eating disorders runs in families that as biological relatives of people with anorexia and bulimia have increased rates of these eating disorders themselves. Studies suggest that relatives of people with eating disorders is 4 to 5 times higher, with rates higher for female relatives of patients with anorexia. Researchers suggest that there is a shared genetic composition for people with the different types of eating disorders, referred to as the broader eating disorder phenotype. However, eating disorders are not as heritable as are mood disorders and schizophrenia. A person might inherit a tendency to be emotional responsive to stressful situation and as a consequence eat impulsively in an attempt to relieve stress. This biological diathesis may interact with socio and psychological factors to lead to development of eating disorders. Biological set point. Our bodies have a biologically determined set point for weight that is difficult to change. Whenever we move away from this biological set point, sensation of hunger is created. The more we move away from set point, the more and more hungry we become, encouraging us to eat and gain weight in order to return to the set point. Chronic dieting enhances the chances of an individual with bulimia feeling irresistible urge to binge high-calorie food. Neurotransmitters. Serotonin is a neurotransmitter that is involved in obsessiveness, mood disorders, and impulsivity. People with eating disorders respond well to antidepressants that target serotonin, thereby implying the role of serotonin in eating disorders. However, it is difficult to identify whether disturbances in neurotransmitters are causes or consequences of the disorder. 7.5.2 Sociocultural Factors. The following are the main sociocultural causes of eating disorder. Media. All cultures recognize ideal images by which men and women are judged as worthy members of their sex. These images form an essential component of our body image, that is, how we think, feel, and behave with regard to our bodies. Media technologies, magazines, newspapers, television, movies, and now social networking websites provide information about what an ideal body looks. Although, irrespective of one's gender, people are exposed to ideal body media images. Studies report that women are more vulnerable to body image disturbances than men. The body size of women in media is becoming unrealistically thin. Many young women are being regularly bombarded with these unrealistically thin models and actors. If we look at the body shape and size of Bollywood actresses from 1970s and compare them to current-day actresses, we would realize that the construct of ideal body for women has changed from being voluptuous to skinny. Further, use of technologies like airbrushing, digital alteration and cosmetic surgery further increase the unrealistic nature of media images of women as standards for self-evaluation. In many non-Western cultures, for example in India, fatness would be valued over thinness as a sign of prosperity. Thin people were considered to be sickly and/or incompetent. However, over time after exposure to Western media, many Indian women began to express concerns with their weights and body dissatisfaction. Family influences. About 1 out of 3 patients with anorexia report family dysfunction, and it was a factor that contributed to their eating disorder, Totsi et. 199. Eating Disordersal, 2003. The following features were observed in families of people with anorexia: parental overprotectiveness, rigidity, marital discord, control issues, etc. Parents also exceptionally value thinness, dieting and physical appearance. It is common to find family members making disparaging statements about body weight and shape. Although it is difficult to establish causality between family dysfunction and eating disorders, as the direction could be other way round also. For instance, having a member with eating disorder may affect the family negatively, in turn leading to increasing family dysfunction. 7.5.3 Psychological Factors. The main psychological causes of eating disorders are as follows: excessive focus on appearance and internalizing of thin ideal. 2 individual risk factors are the extent to which an individual places importance on appearance and internalization of thin ideal contribute to the development of eating disorders. Excessive focus on appearance is most predictive of a preoccupation with weight for young women, who are generally more prone to anxiety. Internalization of thin ideal means the extent to which one associates thin with desirable, attractive, popular, and being happy. Internalization of thin ideal is related to a wide range of problems that are thought to be risk factors for eating disorder, that is, body dissatisfaction, dieting, and negative affect. Body dissatisfaction. When one's own body image does not match with the ideal image promulgated by the media, then some young girls and women are likely to develop negative feelings and perceptual biases regarding how fat they are. Such biases lead women to believe that men prefer more slender shapes than they in fact do. Also, women feel more stringently evaluated by their female peers than they themselves do. Increased body dissatisfaction is not only a diagnostic criterion for eating disorders, it is likely to cause them. Dieting. Some researchers believe that dieting is a risk factor for eating disorders. This is because many women who developed eating disorders had a history of dieting. However, not all those who diet eventually develop an eating disorder. Some of the factors that mediate the relationship between dieting and eating disorders are body dissatisfaction, supervised diets versus self-started diets, and the negative emotional effect of failed diets. Supervised diets in people are less likely to be linked to eating disorders than non-supervised diets by people high on body dissatisfaction. In fact, researchers conclude that controlled and supervised dieting is related to reduced symptoms of bulimia. Negative affect. Experience of negative affect is a causal factor for eating disorders. Feeling bad makes us self-critical, and we begin to magnify our flaws and shortcomings. It is common to find widespread negative self-evaluations like, "I'm fat, I'm useless, I'm a failure," in people with eating disorders. Negative affect is what maintains binge episodes in, as people usually binge when they are stressed, low, or feel bad about themselves. Eating high-caloric food is comforting and helps them deal with negative affect temporarily. Perfectionism. People with eating disorders are high on the trait of perfectionism, or the need to be exactly right. Perfectionist people are much more likely to prescribe to the thin ideal and pursue a perfect body. Perfectionism leads to rigid adherence to dieting that then drives the binge-purge cycle in bulimia. 200. Mood disorders, psychotic disorders, somatic symptoms and eating disorders. Check your progress. 3.1. Explain biological setpoint. Thank you for listening. Please like and subscribe our channel. 2. How is dieting related to bulimia nervosa? Thank you for listening. Please like and subscribe our channel. 3. What is body dissatisfaction? Thank you for listening. Please like and subscribe our channel. 7.6 Treatment of eating disorders. Treatments for anorexia have been there since some time, however initially they were not so well developed. Treatments for bulimia are more recently developed. Drug treatments and psychological treatments are used, however, evidence for drug treatments are not very strong. Psychological treatment. Initially, psychotherapeutic efforts towards treatment of eating disorders aimed at patients' low self-esteem and disordered patterns of family interactions and communication. However, these treatments alone were not very effective. More recently, short-term cognitive behavioral therapies have emphasized on targeting eating behavior and associated attitudes such as perfectionism and focus on appearance. Cognitive behavioral therapy for bulimia teaches patient the physical consequences of binge eating and purging and the ineffectiveness of vomiting and abusing laxatives for the weight control. They are then advised to eat small portions of food 5 to 6 times a day with at least a 3-hour gap between each portion to eliminate excessive fasting and consequent binging. Coping strategies for resisting impulse to binge and purge and arranging activities so that the individual will not spend time long after eating a meal are also taught. Drug treatment. There is no evidence for use of drugs in the treatment of anorexia nervosa, however there is some evidence of their use in bulimia nervosa, particularly the binging and purging cycle. The drugs proven to be most effective are antidepressants, however drugs alone have not found to have any long-lasting effects on bulimia nervosa. 7.7 Summary. Now that we have come to the end of this unit, let us list all the major points that we have already learned. 201. Eating disorders. Achievement of normal body weight through regular exercise and healthy eating is beneficial for our physical and mental health. However, in some individuals the concern about body weight is somewhat more extreme. They are likely to think they are overweight even when they are not. Eating disorders are defined as severe disturbances in eating characterized by 1. Weight concerns, 2. Body dissatisfaction, and 3. Eating problems that are more extreme than the norm, causing the individual significant distress and dysfunction. DSM-5 classifies 3 major types of eating disorders. Anorexia nervosa, in which the individual eats minimal food and the body weight drops to dangerously low levels. Bulimia nervosa is a condition in which the individual engages in episodes of binge eating, uncontrollable eating, and then indulges in self-induced ways of throwing the food out like vomiting, use of laxatives, or other attempts. And binge eating disorder is a condition in which individuals binge repeatedly but the episodes are not followed by compensatory mechanisms to throw the body out. Bulimia is characterized by recurrent episodes of binging, that is eating large amount of food, typically junk food, than most people would in the same situation, followed by use of compensatory mechanisms, vomiting, excessive exercising, laxatives, dieting, etc., to overcome with the guilt over weight gain. The binge and purge cycle usually begins with excessive dieting, that is almost starving oneself, motivated by a desire to look thin. Extreme diets can aggravate the associated negative emotions like anxiety and stress. While initially, a binge episode feels good, but soon enough the person starts experiencing shame and self-hatred over the loss of control. People with anorexia feel hungry and often think about food, but their intense dissatisfaction with their bodies drives them to almost starvation. DSM-5 has specified 2 subtypes of anorexia nervosa. The restricting type, that includes individuals who diet excessively to limit the calorie intake, and binging and purging type, in which they rely on purging. According to the diathesis stress model, biological diathesis, genetics are neurochemical features that led to dysregulation in mood and eating behavior interacting with psychological vulnerabilities including low self-esteem, need to seek perfectionism, impulsivity, body dissatisfaction, and distorted body image and environmental factors such as media-based pressures, child maltreatment, family conflict, social pressures, abuse etc., leading to the development of eating disorders. The best course of treatment available for eating disorders is a combination of drug treatment and cognitive behavioral therapy. 7.9 Keywords Eating disorders, defined as severe disturbances in eating characterized by 1. Weight concerns, 2. Body dissatisfaction, and 3. Eating problems that are more. 202. Mood disorders, psychotic disorders, somatic symptoms and eating disorders. Extreme than the norm causing the individual significant distress and dysfunction. DSM-5 recognizes the following eating disorder: Bulimia nervosa, Anorexia nervosa and binge eating disorder. Bulimia nervosa, an eating disorder, refers to recurrent episodes of binging, that is, eating large amount of food, typically junk food, than most people would in the same situation, followed by use of compensatory mechanisms, vomiting, excessive exercising, laxatives, dieting etc., to overcome with the guilt over weight gain. Binge and purge. Binging refers to eating large amount of food in short duration, which is characterized as an out-of-control experience. A typical binge episode is followed by feelings of being disgusted with oneself, depressed, or very guilty, leading to purging, that is, induced vomiting. Anorexia nervosa. An eating disorder wherein an individual is significantly underweight because of an intense fear of gaining weight or becoming fat. Biological set point. Our bodies have a biologically determined set point for weight that is difficult to change. Whenever we move away from this biological set point, sensation of hunger is created. The more we move away from set point, the more and more hungry we become, encouraging us to eat and gain weight in order to return to the set point. Body dissatisfaction. The extent to which an individual negatively evaluates one's body and experiences negative feelings towards one's body's shape and size. Internalization of thin ideal. Thin ideal means the extent to which one associates thin with desirable, attractive, popular, and being happy. Internalization of thin ideal is related to a wide range of problems that are thought to be risk factors for eating disorder, that is, body dissatisfaction, dieting, and negative affect.